targeting this pathway has been a challenge with some of the other agents that we had available with high rates of hyperglycemia, rash, diarrhea. With Capivasertib, we see a much more tolerable toxicity profile. Certainly monitoring with baseline hemoglobin A1C and fasting plasma glucose is still recommended. Hyperglycemia rates are still an issue, but fortunately grade 3 hyperglycemia is fairly low, about 2%. In terms of how we monitor for the hyperglycemia, it's important to recognize that fasting plasma glucose and the hemoglobin A1C should be done at baseline. And typically on days 3 and 4 of the on weeks, we're checking the glucose on weeks 1, 2, 4, 6, and 8. So basically the first 2 months, the second 2 days of the cycle, the on time, you want to check the glucose. And I, in addition, have been considering adding prophylactic metformin for those patients that have that baseline hemoglobin A1C in the pre-diabetic range. We saw that as a useful strategy in the Metallica trial. Of course, that was using alpelisib, but we've sort of extrapolated that. And then other toxicities that we need to be mindful of, specifically with Capivasertib, is the diarrhea. The median time to onset is about 8 to 12 days. And in the trial, there was no use of anti-diarrheal prophylaxis, but we need to educate our patients about this toxicity. I also tend to use prophylactic antihistamines. The rash does not seem to be as problematic as with some of the other agents, but still it can occur.